a subgroup of African American males that were exposed to syphilis. They knew that all they had to do was give them a single shot of syphilis and it would have gone away. But instead, they let the disease continue progressing so that they could document that African American males were different than their white counterparts when it came to getting infections. Sure enough, it proved the complete opposite. It did the same thing to African Americans as it did to the white counterparts. And sure enough, of course, with the white counterparts, we never let it get to the point where these people winded up developing tertiary syphilis with massive brain damage. Some of these people actually committed suicide because of the brain damage. And some of those families were actually just compensated during the Obama administration. Obama, decided he was gonna pay out to these families because it was wrong for the federal government to allow the study to go on. The guys were being denied treatment. That's bad. So you see why, as a healthcare worker, it's important to understand this stuff, guys. Your job as a healthcare worker is to always make sure that your patient is well informed. If you don't well inform your patient, then you haven't done your job, and you can lose your license over it. You understand me? So you better make sure your patient understands this. So when a doctor says, go explain this to the patient, you better make sure you go explain it to the patient. Because your license is on the line, and so is the doctor's license. Okay? It's important. Patient must come first. All right. So back to this stuff. A lot of clinical stuff that we're talking about here. So the epidermis, so when we want to talk about stratified squamous epithelium, I'm going to put right there, i.e. example, I'm going to put epidermis of skin. When you look it up in your textbook, sure enough, when you look up stratified squamous epithelium in your textbook, it's going to show you an example of skin. And it's going to put it in a little nice little box and shows you the slide, what it looks like under the microscope. Because remember what we said, we're classifying based on observation, right? We got to look at it under a microscope. So that means this whole idea of understanding epithelial tissue didn't come until what? The invention of the microscope. Does everybody understand? Well, the invention of the microscope was when? Anybody know? No, it was much earlier than that. Yeah, much earlier than that. Anybody? 1800s? It was the 1800s around there, right?
I mean, I know the first one wasn't that great.
So it wasn't. It wasn't.
It was like 100 times magnification, and it still says.
Yeah, you could barely see cork cells, but that was the first. That was Robert Leeuwenhoek, right? Robert Leeuwenhoek. He was the one who created the first. He grounded glass to make these high optical lenses that allowed us to be able to view cells for the very first time. So this is very important. Because we wouldn't know everything that we know if we didn't have the microscope.
Well, I'm sure you might know actually. What's the magnification that you need to be able to see in order to see something?
It depends on what you want to see in the cell. If you just want to see the cell itself and its shape, you're going to need stains. You're going to have to slice it. So you got to take the tissue, you got to freeze it, and you put it through a microtome. It slices it very thinly. Then you fixate it to glass.
Right.
You stain it, and you put it under the microscope, and a light microscope.
Like 100.
You get
It's 40, right?
Yeah, all you need is 40, and you can see. And you go down to 100, so the new microscopes will go down to 100.
Yeah, the one on North is 150.
Yeah, so some because you have oil immersion lenses, you put a little drop of oil on the slide, and then you put the highest magnification on, and it'll actually give you a even better view of it. So all this, guys, it's something that you need to see. You understand? So when you go in your textbook and they're talking about this, they're going to show you pictures of the stuff. How did I learn and memorize this? Well, one, I taught other people. Two, I drew the stuff out. All right? Teaching, drawing it makes it yours forever. Teaching it makes it yours forever as well. And the more you help each other, then the more successful you guys will be. It just is what it is. All right? So simple, one cell layer. Well, just like we have a stratified squamous, then we have to have a simple squamous. Now, again, where would I find simple squamous?
A membrane.
Good. So membrane. So like if you go back to chapter 1, you remember that concept map, that really hard concept map, which is in chapter 1 that you shouldn't have gotten, that asked you about the membranes covering organs, right? So you got a visceral and a parietal layer. Yeah. So every organ in the human body is layered with directly in touch is visceral. And then loosely associated is parietal. And what that does is it creates a sac. And that sac has fluid in it. And so what that does is it really accommodates everything. So heart has its space. Lungs have their spaces, right? GI, because GI is made up of multiple organs, then it's a little different, right? But the reality is that where the simple squamous epithelium touches the organ, they call it visceral layer. And where it comes off the organ and loosely associates to create the sac, they call it the parietal layer. Everybody follow? And so that's a perfect example. The whole difference between visceral and parietal layers that line the heart and the lung and the GI, they're simple squamous epithelium, guys. Simple squamous epithelium. Now, where else would I find simple squamous epithelium? No, wait. All right, so let's say this is my organ. So I'm going to erase connective tissue now. I'm going to erase neural and erase muscle. Let's say this is my organ. So here's my organ. Here's the part that's in direct contact with the organ. And now I've created the sac. So this would be my parietal layer, my visceral layer. Okay? In here we said there's what? Fluid, right? So what do they call these? The general term for this is what they call I just had the name one way, I just went away. So I'll just label this. This is your visceral layer. And that would be your parietal layer. And in here would be the fluid filled sac. So if it's in the heart, the heart we call it what? Cardium. Is everybody ready? Visceral pericardium is the simple squamous epithelium associated with the heart. The parietal pericardium is the part that's not, it's associated with the heart, but it's not direct contact with it. It's loosely associated, so there's a sac in between, a fluid-filled sac. We call that the pericardial sac, and we call the fluid in there the pericardial fluid. Everybody understand? Same thing for lung. If the organ is lung, then we're going to call this the visceral pleura. If it's the parietal layer, then we'll call it the parietal pleura. And then sure enough, in the sac, there's the pleural sac with pleural fluid. You ever understand that? So guys, if there's fluid in there, that means what? That it's got to be diffusing in.
Yeah.
Huh? Didn't we say anytime we want diffusion, we want simple?
Can we talk an example for lungs? Because
We're gonna get
when it diffuses through the head, does it go through the sac, or how does that work? Because doesn't it have to?
No, so this is the entire organ of the lung itself.
Right.
This says nothing about what's going on inside the organ. This is just the outside of the organ.
I was under the impression that when you breathe, the oxygen diffuses through the lungs
No.
and goes to your blood.
Absolutely not. It does, but it does it internally, not externally.
Okay.
This is what we're talking about externally. You understand?
Yeah.
The exchange of oxygen and carbon dioxide is occurring internal, within the organ. Not on the outside of the organ, but within the organ. Okay?
Understood.
So that, now we'll talk about it. So separate of the lung in particular, separate of the lung having this epithelium that's on the outside to keep it in its sac. And by the way, we got one left lung, which is in its own sac. The right lung and the left lung, they're in their own sacs. The heart is in its own sac. Those sacs are never to communicate with each other. Do you understand? Left and right lung are two independent organs. So they gotta have two different sacs. Heart, different sac. GI, different sac. You got me? They should never be intertwined. None of them should be connected with each other. But sure enough, they all have what? A visceral and a parietal layer. Those visceral parietal layers are going to be forms of simple squamous. Now, if we go internal to the lung, when we breathe in, oxygen moves in. When the oxygen gets down into the deeper structures of the lung, because I don't want to go through all the structures that it has to go through to get to the deep part of the lung, it reaches the deepest part of the lung, which is referred to as the alveolar sac, and the alveoli, which are the cells. Those cells are flat, guys. squamous epithelium. Did everybody hear me? So the lung sac, the alveoli of lung, are simple squamous epithelium. Why? Because I need that oxygen and I need it now, damn it. So I want the thinnest possible barrier. And the thinnest possible barrier is my simple squamous epithelium. Everybody understand that? I'll give you a question now. Here's a great clinical question. 55-year-old male. Better yet, I'll give you 55. This is another personal. I know so many people. 55-year-old female, chronic smoker for 40 plus years. Her lung lining goes from simple squamous to stratified squamous. What she got?
That means everything deteriorated to the bottom layer, no?
She got. It's not in the throat. It's in the lung. It says lung cancer. The lung has to be. The alveoli have to be like this. They go from this to that. Do you know what they call that? Squamous cell carcinoma of lung. Eh? Squamous cell carcinoma of the lung. So can cells go from one architecture to another abnormally?
Yeah.
Yeah, it's called cancer. You understand that? My cousin. So that was the lady next door, Mrs. Marinelli. Chronic smoker. I'm gonna tell you her story. Smoking, man. Chain smoking. She would go through like a pack and a half in a day. 55, barrel, beautiful woman when she was younger. As she got older, her chest got more barreled. You'll find this out in respiratory. The reason for that is because the hypoxia. And then all these chronic changes that happen in the lung, you get that over time. Now all kinds of just, and then sure enough, what is she doing? She got one cigarette in the hand and the oxygen tank in the other hand. Shit you not. Shit you not. In her house. So what her husband used to do, go downstairs in the basement while she was on the first floor. He's like, yeah, if you want to kill yourself, be my guest, but I'm going to be downstairs.
My great aunt has asthma and she still smokes.
Yeah, it's nonsense. You don't want to, you got asthma, you don't want to be touching cigarettes.
She smokes and she uses the inhaler at the
That's
same
not
time.
good.
The tanks are flammable too, right?
Yeah. Yeah, just they look good. He's walking around there. Like, man, people just never learn.
Long-term smokers are less threat to cancer than short-term smokers. I'm under that impression because of tolerance.
I have to look at the data, but I can tell you that it doesn't, what really matters is not whether you smoke for a short period or long period. What matters is how much you smoke.
Yeah.
Because it's the amount of
instances where they smoke like literally over the weekend and then they develop cancer versus people who smoke for
because it's not just about what you smoke, it's about the genetics that you inherited. There are some people, you ever see that commercial with the guy in the wheelchair?
Yeah.
He's like, I never wish I smoked. Because what? He got Berger's disease. Berger's disease is it's called thromboangiitis obliterans. Listen to the word. You guys don't know this stuff. This is pathology, right? Thromboangiitis, right? Which means, thrombo means what? Blood clot. Okay. Angiitis means inflammation of the blood vessel. And then obliterans means what? It means I'm destroying it. Everybody, like, I obliterate. Means I'm destroying the small little blood vessels with clots and whatever else. And inflammation. Doesn't sound good, does it? Sure enough, what happens? He's losing fingers. How else do we lose fingers, guys? You know? Loss of blood flow. Everyone agree?
Yeah, and then it turns.
What's the most common form of loss of fingers?
Frostbite.
Frostbite. You go up north, and then you get caught in a snowstorm, and you can't get out of it, and then you're trying to figure out how to survive. And your body's going to preserve your lungs and your heart and your kidneys, but what is it going to do? It's going to chop off your fingers. That's what it's going to do. It's depriving your skin and nails of blood supply. And that's why you'll start seeing the skin go black.
Doesn't it do it to the nose?
When else does someone's skin go black? Anybody know?
Well, I think we said it's for lack of blood, obviously.
Yeah, lack of blood flow, but who else has blackened skin in the periphery that winds up having chunks of their skin fall off over time? It's a metabolic disease. It's insidious. Diabetes. Diabetes. I used to work in physical therapy, and people would come in and have chunks of their heel falling off, black. you got to cut it all away.
That would amputate the foot.
Oh, now you got to amputate the foot because it gets too black and it gets too dangerous.
What about gout?
So gout doesn't, I mean, I can't tell you that long-term gout won't affect, say, like the blood vessel wall. Hypercholesterolemia is another one. Excess cholesterol in the bloodstream. So there was an African-American guy on my cutting table. Big African-American guy. Like maybe about 6 foot, let's say about 6'4", maybe close to 300 pounds. May have been an ex-athlete, maybe a retired athlete. Well, he was so jacked up that they had a tube connecting one main blood vessel from the leg to the other one because it was claudicated. That's a hypercholesterolemia, man. Yeah. Stuff is dangerous, guys. So the idea here is when you look at epithelium, you can find a lot of places. So here I'm going to tell you. Simple squamous is not only found in the alveoli of the lung, but because remember I told you that I need a good blood supply from very early on, yes? When I'm developing as a fetus, I better have a good blood supply, yeah? Because I got to get oxygen from the placenta, from mommy's uterine walls. I got to get oxygen from mommy's uterine walls and her uterine blood supply. I got to get it into my brain, my kidney, my heart, my tissue. You understand? So you better have a good cardiovascular blood supply. Well, sure enough, that cardiovascular blood supply starts with a simple capillary tube, guys. You understand me? Capillaries are also made up of simple squamous epithelium with a basement membrane. Remember, we got to have the basement membrane, otherwise the cells fall off, and the cells have to be stuck to the basement membrane. Otherwise, we don't have tissue. So capillaries of the blood vessel are another example of an area where we will find simple squamous epithelium. Why capillaries, guys? Capillary to the brain. Why would the capillary to the brain have simple squamous epithelium?
The blood.
Well, is your brain always on?
Yeah.
Everyone agree?
Yes.
Yeah. Brain's always on.
Except the cells.
So if the brain's always on, what does it need?
Blood, oxygen.
It needs glucose. It needs oxygen. You understand? And where do those two things get fed into ultimately?
The arteries, the capillaries.
No, to each of the cells in the mitochondria, and then the cells can burn it for fuel, right? So the glucose and oxygen are coming from the capillary, they're leaving the capillary, and they're going into the tissue. Did everybody hear me? They're going to the cells that feed that tissue. So capillaries have simple squamous epithelium. Okay? What did we say? We said the serosa, right? The serosa is simple squamous epithelium. These layers of organ that we're talking about, simple squamous epithelium. Capillaries, simple squamous epithelium. Alveoli, simple squamous epithelium. Everybody understand? Now here's what's the cool thing. Now imagine we're on a train system, right guys? But we're doing Magic School Bus train system thing, yeah? Anybody ever remember Magic School Bus? Magic School Bus! Yeah, Magic School Bus! Now watch, now. We go out on the Magic School Bus, we jump in the Magic, and then we inject into the bloodstream. Okay? And it's really interesting. So if I inject into the bloodstream, let's say we're starting at the heart. Okay? Let's do it right. Blood, so we're not in cardiovascular, but I want you to understand. Blood vessels, guys, you got veins and arteries. And you got capillaries. Well, sure enough, that same simple squamous that lines the capillary is continuous with every vein. So if you get injected, if we inject IV, we go into the brachial vein, we're going back, right? We're coming up here, we're going into the heart. The inner lining of every one of the blood vessels in your body, the inner lining of every one of the blood vessels, guys, has the same simple squamous epithelium. It's consistent throughout. The lining, when you go to the inside, so there's 3 layers of the heart, there's 3 layers to the blood vessels. The inner lining, the inner layer of the heart is consistent with the inner lining of the blood vessels. And that is simple squamous epithelium. Did everybody hear me? That's the way it has to be. So we're making a really simple tube at first. And then what are we doing? We're making it more complex. We're making it a simple squamous epithelium tube. And then we're going to put smooth muscle around it to make it an artery or a vein. Did everybody hear me?
Yes.
because the veins and arteries have layers, but not the capillary. The capillary is just the simple squamous epithelium by itself.
So that's the difference.
That's the difference.
Okay.
And that, again, what do we need this for? Diffusion, diffusion, diffusion. Simple squamous is for diffusion. It's for diffusion. Form, fits, function. Stratified, protection. Protection. Acts as a barrier. So it retains fluids, prevents foreign particles from coming in. This is why the penis and the vagina are both stratified squamous epithelium. So the epidermis of skin, vagina, so that the lining of the vagina and obviously the penis, because there should be a lot of friction going on there. The nipple, right? Because when a baby latches on, as long as they don't have teeth, right? Because it doesn't matter how many layers you got if they got teeth. Understand? That's about 6 months. Right? So good luck trying to breastfeed beyond 6 months, yeah? I know some women can still do it. But it's very hard because by a year they got teeth on them, then they're just going to be biting all day. So, guys, anywhere where there's friction, anywhere where there's excess friction, I got to reduce it. Okay? Any questions so far? All right. So,
I have a question.
yeah.
Does parts of your skin that can produce hair cells have an extra layer? Or how does that work?
So skin, the reason why skin has a fifth layer in the palms of the hands and the soles of the feet is due to the extra friction.
Right.
Because here we're manipulating our environment. This is what allows us to be human, right? Is the fact that we can hold the smallest little thing and roll it.
Mm-hmm.
Right? You can drive somebody crazy just doing this all day. Right? Just come up to them and produce that little sound. Give them nothing else to hear but that. And drive them crazy. So that those fingerprints that we have, those ridges,